So a couple things I'm going to talk about. I'm going to start off with artificial disc versus cervical disc fusion, or cervical fusion, I should say. And then I'm going to go over more anatomy and some of the other procedures that we do. And then eventually I'm going to go over lumbar spine as well. I'm going to do a demonstration to show the anterior cervical procedures that are most commonly done. And in the lab, it'll be the posterior procedures for the neck, and then the posterior lumbar spine, which is 98% of typically what we do. So you can see that anatomy, and then we'll sort of deconstruct some of the anatomy after you see the surgical anatomy, so you guys get a feel for where things are and where they aren't. And I'll expand more on that in the lab. So our anterior cervical fusion versus disc replacement. The disc replacement has been around now for about 6 years. FDA approved for 2 levels. In my opinion, a way better option than a fusion if the patient's a good candidate for it, meaning they're not arthritic or not unstable. Those are usually 2 reasons they wouldn't be a candidate for an artificial disc. Only 2 levels so far, right? Yeah, that's the FDA approval. You can do more than 2 levels. It's off-label. All right? Any levels. It's got to be between C3 and C. Yeah, so not specifically 2 levels of the cervical spine, but 2 levels somewhere in the cervical spine, typically from C3 down to C7. Okay? If you do try to do more than that, or hybrids, which I think are actually a good idea, you get a hard, difficult time with insurance companies outside of work comp, but just your standard, Blue Cross Blue Shield and things like that. I think we'll see more hybrids, meaning that you'll see a, really arthritic damage level that's causing a problem with a level above that's not in terrible shape, doing a fusion at one level and an artificial disc above. I think that'll get more traction as time goes on here, because I think it's a very good idea, rather than just fusing both levels. So the insurance companies are trying to say, hey, this is what we think should be done based on this. Well, let me be the physician, you guys pay the bills. For their standpoint, we get a lot of that. And it's just like the patient's outcomes are better. So anyways, that's in the future. So anatomy-wise, there is bones, discs, okay, bones, discs, and nerves. That's what we're mostly concerned with on a regular basis. But we've got to make sure that we understand that the soft tissues are an important part, and that's a lot of the injuries we see, particularly in the occupational arena, because it's not, usually they're not a structural injury. Most of the injuries aren't terribly traumatic. It's whiplash, car accidents, falls, typically soft tissue sprains, and unfortunately they tend to be dealing with them for several months on end, which is kind of overkill. Typically they should be back and ready to go in 6 weeks to 8 weeks. I see patients routinely that are 4, 5, 6 months out from an injury with neural changes on MRI. Just got to move the ball along. And I think a lot of that has to do with just setting expectations in office, right? This is what you can expect. 2 weeks from now, we're going to be doing this. 2 weeks from now, we're going to be doing this. 2 weeks from now, we're going to be doing this. Okay, you're a human being just like everybody else. You'll fit the mold. Okay, it's just there are exceptions, but it's pretty rare. But I think if we do that on day 1, you don't get as much blowback from the patients who are like, oh, no, it's still hurting. Well, no, you're doing okay. Everything's fine. Just got to keep encouraging them and keep them on the rehab track. It's pretty important because I think it gets them back where they need to be when they need to get there. So soft tissues we talked about. So a lot of muscles back here, multiple layers. You'll see that in lab. Ligaments in between the bones. And this is a pretty important structure for the spine, meaning the vertebral artery is in the spine. It's within holes of the bony foramen or holes in the sides of the spine. So I'm not a big fan of chiropractic care for the neck, because that artery can get injured with manipulation. Thoracic, lumbar, spine, I'm more okay with if it helps loosen things up and get you feeling better. But I'd stay away from the neck. This is sort of a cross-section view. That's the vertebral body where the disc goes. These are the facets in the back, which are the joints behind the spine. Spinal cord and here nerve roots come out. You'll see this much more clearly in the lab. This is a frontal view, which is what's going to be on the table here of the spine, or anterior view of the spine with discs in between bones, foramen where the nerves come out. The vertebral arteries would typically run here. X-ray, pretty straightforward. Lateral view, anterior, posterior, spinal cords in this area right through here. We're making sure to watch alignment, disc space heights. Same thing over here as well. You can usually see arthritic bone spurs on the sides here if there's a problem. MRI is going to give us a lot clearer image of the soft tissues, disc herniation, spinal cord compression, what a fusion looks like, taking out the disc, putting in a piece of bone or a spacer filled with bone, a plate on the front to stabilize or immobilize the spine. That's the sort of the gold standard it's been for 50 years. Now with artificial discs, we're doing less of that. So surgical management, basically fusion. We basically have 50 years of clinical experience. Like I said, we've known this inside and out, backwards, forwards, upside down, inside out. Okay, we know a lot about it. It does have downsides because you now no longer move at that level. Discs above and below have more work to do and therefore have problems or wear out and have to do more than they should be doing. Okay, and that's typically where we see problems. Many studies have been shown increased range of motion, or what I would say is abnormally increased range of motion, or wear and tear at levels above and below the fusion. Okay, so this disc above, and it's usually the one above or below, has got to take up the slack for this one, tends to wear out worse. And this is where I was talking about hybrid constructs. Okay, so when we do a fusion, if you have a disc above that has some pretty good wear and tear to it, but it's not really arthritic, it's bulging, and there's causing issue with nerves, it may not be symptomatic. It may be, depending. It is a good candidate because if you do a fusion, that disc above is going to be a problem probably within a year. Okay, and they're going to be back in surgery for another surgery because of that reason. So if you can do an artificial disc next to it, you don't lose anything. You have the same motion there. Now you've actually gained in the sense that you prevented them from having another surgery because it's no longer a potential injury or potential problem down the road because the artificial disc doesn't degenerate, doesn't herniate. And as far as we know, 15 years from European trials, they're doing quite well, not having any issues particularly. But we got to get our own studies because everything in Europe tends to work. It's like no matter what, it's 120% success rate. Slipping, no. That is a concern, right? There's a risk. It depends on your indications and if the patient's fit qualifications to have an artificial disc. The two things you need to worry about: the patient has underlying instability, or they have some slippage from arthritis, or they have really soft bone, really bad osteoporosis. Then it's going to settle, or it can get loose in there because the bone gives way. So now that thing can wiggle out. But I will tell you, by and large, this isn't going to be typically used in patients who are of the osteoporosis age. It's pretty rare for patients to have it younger, thankfully. So by the time they're bad enough to be osteoporotic, we don't need to worry about doing an artificial disc. Usually they need a fusion because it's arthritic and worn out pretty bad. Secondly, from the standpoint of instability, you usually can pick that up with the studies ahead of time as far as what's going on. And once this thing is in, I'll tell you, it is not easy to take it out. I mean, I've had cases where it's in, it's a little more posterior than I want it to do. To get it back out and reseat it is not easy. I mean, you have to kind of open it up more, really wiggle and fudge with the thing to get it to come out. All right. By the way, I'll pass these around just so you guys have a little show and tell. So this is a lumbar fusion device replacing pedicle screws, so you guys can take a look at that. So that takes the place of using pedicle screws, which makes us, or allows us to use a much smaller incision so patients can recover faster. This is the implants in the disc that we use to help increase stability and also use a smaller incision to get patients outpatient fusions now that we're doing. All right. And this is a model of an artificial disc. So when you guys look at it, be careful because this comes apart. It's only magnetic. So then this thing will fly out. I do it all the time. This is like the 8th one that's been in here probably. So just kind of, you'll see how this thing moves around. And what I want you to pay close attention to is when you do move this, you'll see the spacer in the middle move as well as the actual bones too. It kind of slides around in there. And if you see on top, you can move your finger around and see how it moves around. Oops. Turn that around. There it goes. So the study that they did for the artificial discs basically was 500 or 600 patients. Whoops, too fast there. 600 patients. For every one fusion, they did 2 artificial discs, so they get enough numbers to get a pretty good idea, some good data on what was going to be the outcome of the study, comparing the artificial discs versus a fusion. So they did 1 and 2 level surgeries and then followed them for 2 years. Okay, just give you an idea what this thing looks like and how it works. Picture or video speaks 1,000 words here. Let me see if I can get this to play. Just gives you an idea what the range of motion differences are between using artificial discs or doing a fusion. All right, a little cartoon. So things moving segmentally the way they're supposed to. This is 2 levels of artificial disc. And that's a fusion with a plate, right? So you'll see that that doesn't move at all. You got too much motion going on there and there. So you'll see the differences when they overlap. These, keep in mind that that's just one range of motion, one plane. That's flexion extension only, not lateral bending. You'll see a similar difference. Okay, and they don't mention or they don't show rotation here. So you can imagine rotating the spine, looking over your shoulders. It's going to be obviously impacted as well. All right. So this is just basically, I'm going to go through these pretty quickly. What they're showing here is when patients who had a problem within 2 years at the level above or below where they had surgery. So not at the level they had surgery, above or below. Blue is a fusion, green is an artificial disc. You can see the differences. I mean, the data are pretty clear, pointing out there's going to be more of a problem with fusions, okay? Why is there any issues with artificial discs? That could be a question. Well, because patients have some degeneration. Patients have other problems in their neck. These aren't perfectly, not every one of them have perfectly normal spines other than the disc that's being operated on. So they're going to likely have some problems nonetheless. It isn't a preventive measure to prevent problems down the road from other levels. They can still have issues. So how many surgeries were done? Similar sort of trend. Much more common in the fusion population. Now, this is secondary surgeries at the index level. What is the index level? That's the level they had surgery on already. Okay, so at the same level, you can see the differences in repeat surgeries. Usually, this is because of a non-union. The bones don't heal, smokers, or they're not compliant, rejected the bone graft. So different issues that can happen, or just plain old don't heal. Sometimes it happens. Artificial disc. This could be due to those instability issues, or patients were had some osteoporosis, maybe had some softening of the bone, depending on the age of the patient.
What's the difference now than, I don't know, when I was in Kentucky, they quit doing them because they were dissolving. There was all sorts of issues with the disc. What has happened that they are so much better now?
Which disc?
The
Artificial disc?
Yes.
Okay. Was it lumbar spine? How long ago was it?
Oh, God.
6-7 years ago?
It's been 10 years.
Yeah, that's the Charité. The Charité disc was the first artificial disc that brought to broad market sort of awareness and use. Okay, probably prematurely. The engineering and design of that was actually quite poor because it wasn't held. 2 reasons: the implant itself wasn't held in the intervertebral space very well, and that plastic. I don't know if you guys have seen the artificial disc yet, but that plastic bearing wasn't contained in between the 2 plates. So when it happened almost routinely is when patients went into extension or bending their back backwards, the vertebral bodies would open up and that thing would shoot right out the front. Because nothing kept it in. There was no way of keeping it in. But if you open that, take those 2 apart, you'll see 2 posts, like 2 little metal posts that keep it from, there's no way it can come out. It's impossible unless you dislocate your neck completely. You're probably going to have bigger problems at that point. That's the least of your issues at that point. So 2 things. 1, it was pushed to market too fast, okay? And 2, it wasn't designed very well. So an implant not designed very well. I got an engineering background, and looking at it, I was like, I don't like the looks of this thing, just based on how it's supposed to work, and take faith that it's going to stay in there. Okay, well, I'll just watch and see what happens before I subject my patients to it. And sure enough, they pulled it off the market because there was a 1% death rate, okay, with the lumbar spine. So 1% death rate for a surgery is on the basically aligned with what heart bypass surgery is, a coronary bypass surgery. It's a 1% death rate, right? So you're having an elective artificial disc surgery done and you got a 1% death rate. That's catastrophic, it really is. So they pulled it because of those reasons. So bad design, pushed to market too fast, and one caveat that you learn hopefully in training and in practice, you tend to want to stay behind the cutting edge about 2 years. Okay, because the cutting edge often doesn't work. All right, ends up cutting the wrong things. When there's a problem like this, would rupture the aorta or more likely rip the inferior vena cava, and patients would be dead on the spot, and then they bleed out within seconds. I mean, it's just a huge vein in front there. It doesn't take them long at all. So that was the concern. Or if they had to have it revised, the scar tissue and trying to get to this thing would cause injuries to those vessels as well, and patients wouldn't make it. So anyways, from the standpoint of just surgical pearl or kind of medical pearl thing, it's a good idea to stay about 2 years behind and see how the outcomes are coming and see what's going on out there before you jump on the bandwagon and make sure, because you don't want to put your patients being guinea pigs. I mean, it's that simple. So that's the difference between that and now and this, okay? This is designed to have, if you look, well, I'll show more on the actual implant here. You'll get a look at it, of why it stays in and what its stability is. So this is what it looks like actually in a real person in surgery. Some of you may have seen this before. So you can see it changing orientation between it's moving. I mean, it's functioning. It's doing what it's supposed to do. So we did that. Return to work for artificial disc. This is the study's numbers, okay? So when you're doing a study like this, you're uber conservative because you want things to work and not have issues and make sure you got everybody on the same sort of treatment algorithm. So they had patients returning to work with one level for the artificial disc at about 30 days and 45 days, so let's say 4 weeks and about 6.5 weeks. And then fusion was more along the lines of 6 weeks to maybe 7, 8 weeks, more like 8 weeks, 9 weeks. So quite a bit difference, right? And that's not return to regular duties, that's just light duties, okay? So they really wanted to protect the patient, make sure this thing started healing in and start going the right direction before they let them get back to some more normalcy of work. So that's a week and about 3 week difference. In reality, I'll send patients back to work if they're up to it the following week. Like if surgery's on Friday and Monday, patients are asking, can I get back to work? But those are motivated. They want to get back to work because they're like, hey, I got office, if they're attorneys, accountants, they're not doing heavy manual labor, boiler makers, iron workers, pipe fitters, things like that. They can get back to do light duties the next Monday. They want to take every other day or do half days. They can get back to work, start driving once they're off pain medication because I don't have them in a collar. I want them moving right away because you don't want the disc immobilized to scar in, right? As far as fusions, they're in a collar for 2 weeks, back to work, usually 2 weeks light duties, sometimes 4, depending what they're doing and how bad their symptoms were. So, and if it's multiple level or not, depending on what's going on there. And I'll go over this in the lab. This is just a decompression for when you have multi-level compression of the spinal cord. This is the back of the cervical spine. So we're making a trough in the bone here, removing that chunk of bone here to decompress or unpinch the spinal cord. All right, that's a procedure you'll see actually in the lab.